you really see the reaction?
No.
It's really hard to see the reaction if their eyes are if it's so bright, you know. So you want to measure the resting pupil. So to do that, or this one doesn't have it. I guess okay, this one would be the perfect one. What's your name?
One.
One. Okay. So you just kind of look at his pupil. Look here. What do you think he is?
Good. All the way.
Do you see?
Oh yeah, I see that, but I.
What is his pupil at? Does anybody want to tell me? Come here and see what the Juan's
Guess a
pupil
4 or
is.
5 is a little far away.
Oh, he's like around a
It's ball.
4.
Four.
About a 4, right?
Five.
Yeah.
4.5.
All right. So let's turn off the lights and
Can someone turn off the light?
Sorry, I'm all up in your face.
okay.
He's President Matera here.
So whenever you want to light on your patient's pupil, you want to go from the side. All right. So let's see what his pupil is going to go down to. Bam. You guys see that?
Yeah.
So what is that? 4 to what?
2.
Yeah, it was 4 to 2. And that was brisk, right? It was like instantaneous. Just so you want to also check for consensual closing of the eyes. So consensual is you want to check when you're lighting here, is the other eye closing also? All right, want to check for that. Okay, accommodation. So accommodation is, are they able to converge and are they able to go from far to close or close to far? All right, so that means that their eye is able to accommodate. So Juan, look at my pen. Follow it. Follow. All right. Go ahead and turn on the light.
See if I pass the sobriety test.
Okay, Juan, I want you to look at that book right there, okay? All right, look here. So did you guys see his pupil move? All right, so that means he's able to accommodate, all right? So when he looks here, it will like close a little bit, okay? So that's your accommodation. So Juan has perla, all right? Pupils equal, round, reactive to light, and accommodates. All right, hand grips, you guys know that, pushes and pulls. So whenever you do any assessment, you always want to do it bilaterally, okay? If they have one side, if they have 2 of it, you want to check both of them, all right? Always. All right. The chest, shape of the chest, if it's normal size chest, a normal shape. If you guys have a barrel chest, do you guys know what a barrel chest is?
Talked about that.
So what does a barrel chest look like?
It's the ratio is off. 2.
Okay, so what is your ratio right now? What is his
1 and
ratio?
2?
1.
So that's
2 sideways.
2 parts, right?
Wide.
And then 1 part here. So if they're barrel chests, what does it look like?
2
2 to
2
2.
to 2 or 3 to 2 maybe.
It's 1 to 1.
Oh,
So one
Reducing
side
it.
is the same as, yeah. So 3 to 3, yeah, that's the same thing as
You
1 to
reduce your
1.
fraction.
So what it is one size,
It's the same.
yeah, it's like a round barrel. And you guys know who has barrel chest? Why is that?
They're trying to breathe harder.
So they're muscular, they work out just by breathing, So
Accessory mostly.
yeah. All the years of accessory muscle use, they get big, But I mean, you
Working
don't
out
want
the
to
wrong
be big
way
like
this
that, by
Working out that
struggling to breathe. But that's what it is. Their accessory muscles has to be strong for them to be able to breathe. I mean, it's a terrible way to live, but that's how they look like. That's why they're barrel chested.
Better than alternative.
So does everyone understand that? Okay. All right, auscultation. All right, when you want to listen to the chest, you want to listen snake-like pattern, okay? And you listen to full cycle at each site, all right? So 1, exhale. Then down. and then do the same thing on the back. All right.
There's 6 lights on the front.
Well, it's actually should be like 6 in the front and then 8.
8.
2, you know, your axillary,
Right.
and then 8 in the back. So you listen full cycle at each site. All right. When you listen to, and also when you listen, you want to make sure that they're what? Would you listen over the clothing?
No.
On the skin.
So you're gonna have Juan remove his shirt and all that, okay? When you guys listen to him, or when you listen to your partner, all right? You always want to auscultate on skin, not on. Because why is that? What's the problem when you auscultate in
You
the?
get discrepancies in the hearing what you hear.
Yeah, when you listen for when you listen to the lungs and you hear crackling. Crackling kind of sounds like, you know, like this, you know, like. I mean,
Rubbing.
yeah. So if you do it on clothing, you can't rule out if you're listening to just the friction of the shirt on your diaphragm or his real breath sounds. That's why you always want to listen to skin. All right. So for your heart sounds, so you listen to the 4 valves. Do you guys know what those 4 valves are?
AV valve.
Pulmonary,
Tricuspid
mitral,
valve.
and then tricuspid.
Tricuspid and then mitral.
Oh, tricuspid. Yeah, there you go.
Yeah, all patients take meds.
Yeah. So, what sound would be strong on your semilunar valves?
S2.
S2. There you go. That's good. That's just I don't know if you guys would need to know that, but why would that be?
That's when it's relaxed.
Some repolarizing?
The beginning of diastole.
Yeah, because that's where it's strongest that you can hear it. When they go diastolic, you know, it reverberates there so much better. You'll hear your S1 so much like louder than your S2 in your AV valves. Okay, your tricuspid and your mitral. I don't want to say all this now just because I don't think you guys need to know that right now. But all right, so S1, S2. Do you guys know what that is? What is S1 and S2?
It's the valves closing.
So S1 is the tricuspid and bicuspid valve, and then your S2 is your semilunar valves.
Yeah. So it's just the shutting of the valves. Okay. So when when your AV valves close, they go lub, and then your semilunar valves they go dub. You know. So lub dub. That's all it is. It's sounds of the valves closing. So when you try to listen for extra heart sounds, you try not to listen for extra heart sounds. What you're always listening for is your S1 and S2. And all the other extra stuff, that's your extra heart sounds. All right? So you really want to identify S1 and S2. If you can identify that, and if there's some other sound, you know, I mean, who cares if it's S3 or S4? You know, when there's S3, S4, your doctor's probably going to order an echo or something because they probably don't know what that means too. So, but what that means is like the patient's probably overloaded and the valves like make extra sounds, right? All right. Okay, palpation, your Capri-Bowl. You guys know how to grade edema? How do you grade edema?
So look for bony prominence.
Higher the
Chin.
number, the
Okay,
deeper,
so what's grade 1?
less, like not as much.
What is not as much?
Like when you press in, it's just maybe a little crease.
You can press as hard as you can. So if you press harder, would that be a grade 2?
No.
So what
It's
makes...
like that.
Time for
Okay,
The recoil.
so what's grade 1? How long is the...
like 1 to 2 seconds.
Okay, what's grade 2?
2 to 3, more than 3 seconds, 3 plus.
No. Who told you guys that?
That's what I've always seen.
That's wrong. That's completely wrong. All right. So, grade 1 needs to recoil in like instantly, pretty much. Like grade 2, I think it's like 30 seconds. Grade 3 is like 2 or 3 minutes, and grade 4 is like 5 minutes. I don't know exactly the exact time, but that should be in your assessment book or something. That's how you grade edema. All right. It's not 1, 2, 3, 4. Oh, this is grade 4. No, that's not how you grade edema. All right. And a lot of people don't know how to grade edema, so you guys will know how to grade edema.